Good evening, everyone. My name is Mark Lee, and I would like to thank everyone for joining the webinar tonight, entitled Life After Surgery for Adolescent Idiopathic Scoliosis. We are set to begin very shortly after a few introductory remarks, and we'll get going very soon. Just a note to the audience, please join in listen-only mode. Otherwise, we'll be able to hear all the pets running around in the background and the children arguing. So make sure you hit listen only. So the presentation is a work of the Scoliosis Research Society, which was founded in 1966. It's an international society focused on treatment of spinal deformity, scoliosis, kyphosis. Members include over 1,000 of the world's leading spine surgeons, researchers, physician assistants, and orthosists. We are committed to research and education of clinicians and patients. While we're waiting for the slide to move along, I just wanted to let the attendees know that you can submit questions during the broadcast via the question function, and also view questions asked by other attendees. You can also vote on specific questions. The ones that you vote on will kind of rise to the top and will be asked of the panelists at the end. And the panelists will answer the questions to the very best of our ability at the very end of the presentation. Also, a recorded version of the webinar is available on the SRS website under the Patients and Families sections for patient webinars. So, scoliosis surgery has a long history. It began with Hippocrates, who felt that a little traction on a patient, along with a little pressure by a muscular kind of person along deformity, would very much help the scoliosis. You can go to the next slide. As the years progressed, surgery became a thing, and surgery was initially done without any type of instrumentation. An incision would be made in the back, and a spine fusion would be created. And then the patient would be placed into a cast for a very short period of about 6 months to 1 year, and then you'd be broken out of the cast. You can advance to the next slide. So along came Harrington, who suggested that maybe instrumentation would be helpful for the scoliosis. And this involved putting metal in the back, which was thought to be heresy at the time. But he achieved some fantastic results with a single fixation point up above and below, consisting of hooks and a single rod. And go to the next slide. The surgical technique was further advanced by applying multiple fixation points in between, and then utilizing 2 rods to stabilize the construct further. Well, after looking at this a little bit, people realized that maybe the fixation point, the actual attachment of the rods to the bones, was really the limiting factor in deformity correction. So along came these instruments called pedicle screws, which are essentially implants placed through narrow canals along the spine. This really advanced the ease of the surgery, as well as our ability to correct the deformity. Go next slide. Nowadays, surgery for scoliosis looks a little something like this. And at the very end, you'll typically have 2 rods, some hooks, and some screws in between. And the deformity usually is very well corrected. Now, we have really a lot of information about the surgical approach for scoliosis, but we have almost no information or very little information about what to expect after surgery. So the focus of this particular webinar really aims to answer the question, what can we expect after you receive surgery for adolescent idiopathic scoliosis? So we will be going through several topics. First, pain and hospitalization. And we'll be talking about going home and returning to normal life. We'll also be talking about long-term concerns. And then we'll have a question and answer session at the end. Just to mix things up, I'd actually like to throw out a question to the audience initially that you can answer at your leisure during the presentation. And this is really to figure out exactly how many participants we have and to figure out kind of where you are along the surgical spectrum. So the question is, how far along are you in the surgical treatment of scoliosis? And there are 3 options. So at your leisure, please begin to fill it out. these are our disclosures. And without further ado, I will introduce the first panelist, who is Kristopher Lundine, who is an orthopedic surgeon at the Royal Children's Hospital, all the way in Melbourne, Australia. And he'll be talking about post-op pain and hospitalization.
Thank you very much, Mark. And thank you everybody for logging in and taking a look at this webinar. As Mark mentioned before, please feel free to post questions during this process at any time, and we will look at the questions as we go through and try to answer them to the best of our ability. And then, of course, this webinar will also be available on our website to view at any point in the future. This talk is really going to focus on kind of the hospital stay that you'll have after surgery for scoliosis, and looking at both pain and some of the other aspects that we'll look at to help basically optimize your care. The hospital experience is really unique both to the individual patient as well as the each individual center will have different experiences and different ways of doing things. That is really important to know. There's going to be differences from what I'm saying based on where you're having surgery. When we're talking about pain, it's really important to understand that every individual will have a unique experience when it comes to their pain. And adapting our pain control methods to your individual needs is really important. When we speak about pain, there's both the physical nature of pain and the psychological aspect of pain. People who have really mild pain, we tend to focus more on the physical nature and giving you pain medications and things like that. People that have more severe pain and more chronic pain, oftentimes we'll get teams involved that will help deal with the psychological aspect of pain, because it can have quite significant effects on things like depression and anxiety when it comes both to the surgical aspect and the rehabilitation afterwards. We know from studying scoliosis that those with more pain before surgery tend to have a little bit more pain after surgery. But most patients do tend to improve in terms of their pain scores over the course of surgery and the rehabilitation afterwards. Just advance the slide. As Mark mentioned, there have been quite significant advances in the surgical treatment of scoliosis and how we change the alignment of the spine. That typically, that type of an X-ray is the type of change we're looking at now. Is someone starting off with coronal imbalance or a shift to the side of their spine, rotation of their spine, and we're putting in screws and hooks and rods to really change the shape of your trunk and change the relationship of that trunk to your lower body to get better balance of the spine, which can have a real effect on both the muscle and ligaments in the spine and the overall feeling of balance and comfort with your body. Just advance to the next slide. The immediately post-operative, one of the key components now that's become really talked about and researched is this concept of multimodal therapy. There's going to be many different ways that we address your pain in the early phases to make your pain control as best as possible. The simple stuff are things like Panadol or paracetamol, acetaminophen, Tylenol in North America. And these are simple things that you can take. And then we're going to be using multiple things, either through an intravenous line, potentially in your wound. Sometimes there'll be something called a PCA, or patient controlled analgesia, which is a button you'll actually be able to press after surgery to give yourself a small shot of medicine when you're feeling pain. The nice thing with all these different modalities is that we can kind of hit the pain centers in multiple different ways, both at the site in the spine and also in the brain, to make you more comfortable. People worry with a patient-controlled analgesia, can I give myself an overdose? The answer is no. That's one of the nice things about it, is that when you give yourself a shot, as you start to become more comfortable and start to become a bit drowsy sometimes afterwards, is that you don't give yourself another shot. And so and there will be a limit on the machine as well, so you can't overdose yourself on medication early after surgery. The teams in hospital Sometimes we'll include a specialized pain team that often comes with the anesthetic services, and their specialty is dealing with pain and different pain medications to try to optimize things. Sometimes one medication might not work well for you, so they might switch you to a different medication the first day or two to find something that's working a bit better. When we look at a typical pain course after surgery, the first couple weeks are when things are most sore because of the surgical manipulation of the spine. That everyone has a baseline level of pain, and that might be some days having almost no pain before surgery. Some days that might be a 6 or a 7 or an 8 out of 10 if you're really uncomfortable with your spine. And usually that pain first after surgery, and this is without medication, will go up a little bit. And it's our job as the team in hospital to give you medication to make you as comfortable as possible. It is very difficult to completely take away pain. I can't say that surgery is ever painless, but we have multiple steps to make it as comfortable as possible. And so that early phase after surgery is when pain goes up a little bit, and then usually within a couple of weeks, pain's starting to come down, and that's when you start to go back home and whatnot. So really what we're focusing on here is your experience in hospital. Just advance the slide. Those first day or two, that multimodal therapy will be intravenous through the lines that are going through your arm, maybe a wound catheter to give pain medication directly into the wound, and then an early transition to oral pain medications. It's what is becoming more and more common. We find that the earlier we get you onto oral pain medications, the better and more comfortable that transition is to home, because of course you can't go home with all these intravenous lines going in. So we want to get you onto a comfortable pain set with pills, because you can go home with those pills. And most patients do go home needing some pills that will continue anywhere from 10 days to a few weeks. Every pill affects every person a little bit differently. Key is finding a pill that works for you. So your team will have things that they use routinely. If that pill is not working very well for you, they can find a different pill that's working slightly differently. Again, there's different modalities within pain pills. You've got your anti-inflammatories, you've got narcotics, analogs of morphine, you've got neuromodulators, things like gabapentin and Lyrica, and all these names sound very medical, but these are things that you might become familiar with after surgery, and different things can be used to help adjust pain, and every pill has a different side effect profile to try to make something that works well for you while minimizing the side effects. Of course, one of the most common side effects that we deal with after surgery is nausea, and no one likes to be throwing up after surgery, and there's many steps that we take to try to minimize nausea, but almost all the pain medications that we use, the common ones, the narcotics, do cause some nausea. Trick is the Goldilocks rule. The more we give, the more side effects we get. The less we give, the less pain control we have. So it's finding that right balance for every individual to give you just enough to make you comfortable without giving you too much to make you sick. And again, that's why that multimodal therapy, trying a little bit of this and a little bit of that, comes together to find just that right amount to make you as comfortable as possible. Sometimes that can take a day or two to find that right balance. So be patient with your team that they're going to be doing a few things to try to make you as comfortable as possible. But it's finding that just enough pain medication to keep you comfortable, allow you to get some rest, but not so much that every time you sit up, you're throwing up. Because we don't want that, you don't want that, and we do our best to minimize that. Along with nausea, everybody worries when they come and ask me that they've been starved them all morning because you can't have surgery, can't have food before surgery. So usually empty belly for about 6 to 8 hours before surgery. So everybody comes into surgery hungry. And they're worried that if they're nauseous after surgery, they're going to want to eat. Most patients are not hungry after surgery. It's going to be a couple days before you really want to jump in and have a whole bunch of food. Don't worry, from a nutrition point of view, you will be able to catch up. It's not like your body won't have the nutrients to heal up after surgery, but it's pretty normal to take 2 or 3 days at least before you're kind of getting back to a normal diet. Go really slow. It'll be clear fluids, water, some light juices after surgery. And then we slowly build in more solid foods. You don't want to go after the hamburger and fries too early after surgery because that will definitely make you feel a bit sick. At the same time, when you're not eating very much, the guts are going to slow down a little bit after surgery. So constipation is very, very common after surgery. Both the combination of lying down and not getting around very much for the first couple of days, not eating very much, and then all the medication we give you, all these factors do lead to constipation. We'll give you medicine in many centers to help get the bowels going and keep them flowing as best as possible. But one of the best things to help get the bowels moving is to get up and do some walking. That will really help the bowels out early on. So that's why some of the physiotherapists will get you up and walking as well, as that will help the bowels. Very rarely, some patients, when we stretch out that spine and straighten things up, we get a bit of stretching of the bowels and one of the arteries around the bowels that can really slow down those bowels quite a bit. This is something called superior mesenteric artery syndrome. Big long name that you don't have to remember and don't worry about. But if that happens, sometimes we'll keep you from eating for a couple of days just to allow the bowels to catch up. Very rarely, some patients will need a tube into their nose that goes into the stomach to take some of the gas out to make them feel a bit better. That's uncommon, but it does occasionally happen. And usually this just needs a bit of time, a few days, letting the bowels settle down, and then things will start to catch up. A lot of patients ask me, do I need anything special for sleeping after surgery? Do I have to sleep on my back? Can I not sleep on my back? You can sleep after surgery in whatever position is comfortable. If that's on your side, on your back, even on your stomach, it's okay. Most patients find sleeping on their back the easiest at first, and usually those first couple nights, nurses will come in and help you roll onto your side, because you don't want to spend all your time on your back those first couple of days after surgery, so you don't get a pressure sore and don't get any bed sores on your heels or on your buttocks. So the nurses will help you move around a little bit and try to find that comfortable position. But you don't need any special mattress, you don't need a special pillow. Really, you want to come into hospital, and if there's a pillow you have at home that you normally like to sleep with, you can bring that in. If there's a special sheet or quilt or something that you like to bring in, that's not a problem at all either most of the time. That it's really just being comfortable in bed, nothing abnormal. Expect that your sleep pattern after surgery will be a bit odd for a few days. You'll be doing a lot of napping, and when you're napping a whole bunch during the day, sometimes at night you won't feel like sleeping because you're not as tired. That's normal. It'll take your body a few days after surgery to get back into its normal cycle. The time you spend in hospital will very much depend on your local institution, your local surgeons, and what their protocol is. With current advancements in research and looking at what different centers are doing, it's now quite common that postoperative stays are around that 3 to 4 days. But again, every center is a little bit different. Early physiotherapy, early mobilization, getting you onto oral pain pills has shown that really going home around that 3 or 4 days is very safe, and most patients are very happy with that, because most patients are more comfortable at home in their own bed, with their own bathroom, their own fridge, their own TV, things that they're a bit more used to. And we want to do whatever makes you most comfortable. At the same time, after surgery, if you're not ready to go home yet, and the team there says, you know what, we need to work on a little bit of this or a little bit of that to help get you ready for home and be safe at home, that'll be something that we discuss with you guys, so that we're not sending you home where you're not feeling safe and not feeling supported. A very common question is whether you're going to need any walking aids, things to support you to get around after surgery. Most patients don't need anything. The physiotherapists and occupational therapists will see you in hospital, will help support you after your walk, and you might need a little bit of help in those first couple of days as you're starting to get your strength back. But most patients don't need any extra supports in terms of a walker, crutches, or wheelchairs or anything like that after surgery. Most patients are up walking independently within a couple of days. Of course, the common complications are conversations. What about complications? I really want to emphasize that before surgery, this is a really important conversation to have with your surgeon. Every surgery carries risk. We do many, many, many things to minimize risks of surgery and to make surgery as risk-free as possible, but we can never make risks zero. And everything to do with surgery is about risk management, about making surgery as safe as possible and giving you the best potential outcome. Still, complications can happen. Most complications are minor and will just require maybe a slight adjustment in medication, maybe a bit more antibiotics, maybe some medicine to help the guts to make you feel a little bit better. Occasionally, rare, some bigger complications do happen. Some complications do lead to longer hospital stays, maybe needing a bit longer physiotherapy, a bit more medication, a bit more antibiotics. Bad complications are rare. Mild complications are a bit more common, but most of these do not affect the long-term results. It's really important to discuss these with your surgeon to understand the whole process of scoliosis surgery and what the risks are, so that you know going in what this all means. But regardless, you're going to meet many, many people in hospital. It's not just your surgeon. It's the surgical team, the trainees that are going to be working with the surgeon to help you out, the nurses in hospital, the anesthetic team, the pain team, the physiotherapist, the occupational therapist. Many people are there to try to make your experience as positive as possible, as comfortable as possible, and as risk-free as possible. We're all checking on each other, we're all watching each other, and we're all professionals trying to do the best job for you that we can. Don't worry about remembering everybody's name when you go into hospital. You will meet so many people, but know that there is a large team around you that's trying to give you the best experience possible, and different team members will be able to give you different information and answer different questions to help you out as best as possible. All right, that's the end of my kind of hospital talk. We'll now move into going home with Marissa.
Hi, good evening. Thank you everyone for attending. And I saw on that initial poll that we have almost half of our people that have joined us this evening are gathering information ahead of time in planning for surgery. And what an excellent way to have some in-person education and information. So my name's Marissa Muccio. I'm a physical therapist and I hold advanced certification in scoliosis specific exercise. So not just the general physical therapy, but then after we graduate, there are some advanced certifications, especially within the United States, but certainly they exist globally as well. So this evening we're going to talk about going home. And as Dr. Lundine started to talk about, the plan for going home actually begins before your surgery. So pre-planning with your surgeon, perhaps a visit to the hospital, meeting some of the key team members is a critical step. So for example, we get to know more of the details about your home environment. Does your home or your apartment have a flight of stairs? Then that can be put into your plan so that nursing and physical therapy can make sure as your movement over the few days that you're in the hospital, you can actually practice those tasks. So it matches your home environment, not just the teen who's doing the activities, but even helping educate and direct parents for guiding and supporting during those first few days at home. Let's see if we can advance. I'll try again. Okay. So some parents are really surprised how early movement starts. You know, it's a long surgery and it's sometimes uncomfortable to think that within one day you're going to start having a team help you move. But early movement actually helps to speed the recovery. It helps to decrease the overall pain experience and it helps to shorten your hospital stay. One of my favorite little areas of research that started to show up is don't forget to bring a few packs of sugarless chewing gum. Certain research is starting to show that once your physician has cleared you for eating and chewing, sugarless bubble gum can actually help with some of the gastrointestinal challenges following surgery. So along with the movement, we add, when appropriate, a pack of chewing gum. And blowing bubbles can be another fun way to actually start to get some chest wall and respiratory. So don't be surprised if your PT shows up with a pack of bubble gum. So physical therapy is usually a part of the team, as is nursing, and they'll help to begin to teach you how to move safely within the hospital within those first few days. How to get out of bed, how to stand up, how to sit up and down in a chair, walking to the bathroom, and beginning longer walks. Keep in mind, we call it no BLTs, no bending, lifting, or twisting in those first few days. Nursing is also going to help educate and provide you with the information on hygiene, on how to take care of the wound and the bandages, and your medication plan that your team puts together before you go home. So now you're home. Everybody's usually quite relieved on some level to be home. It feels so much more comfortable to be home, but it's also very common to be a little nervous at first. You've lost that immediate medical team that's there to answer every immediate question. Be patient. Trust the fact that a good team has given you the education and the information and the tools to really help your team transition home comfortably as possible. When you first get home, you might have the desire to just hang out and not move, but it's so important to keep up those daily walks and to actually increase the distance and the number of times you get up and move around throughout the day, increasing that as tolerated. Continue with the no BLT, no bending, lifting, or twisting, and certainly follow your medication plan. These first few days at home is not necessarily the time to try and be brave. You want to stay on top of those first few days, making sure that the pain does not become so limiting to the movement. Movement is your best friend when you're in this healing process at home. So as the days and the weeks begin, how do you get your back into life? Typically, you can return to school within 6 weeks. It's perfectly okay if you're still feeling some fatigue and endurance. If your team doesn't quite make it to noon or 1 o'clock without really wanting a nap, try going back to school part-time for a week or so. This is also the time to introduce a few social outings. There's nothing better than having some BFFs come over, hang out, maybe go for a walk, out for some ice cream. Start to begin to bring back that sense of normalcy. During this time, lifting more than 10 pounds is restricted, as are most all sports activities. So if you've ever weighed your teenager's backpack, I guarantee you I've never come across one that weighs less than 10 pounds. And I've even seen some purses that might exceed that 10 pounds. So throw them on a bathroom scale if you're not sure, but double check those backpacks. Your schools can certainly have a conversation with your school nurses about any modifications, whether you want textbooks to be available in school so they don't have to carry them back and forth. And most schools are pretty open to facilitating that early return. So now we want to get your back into life. The consensus for most surgeons are to allow for postoperative in about 3 months, they can get back to running. 6 months, you can return to your non-contact sports and some contact sports. But certainly by 12 months or 1 year after your surgery, they're usually back to their contact sports, and in some instances, depending upon the specific surgical intervention, you can even enjoy return to collision sports. That is the conversation that can be had on a case-by-case basis. And if you're not sure about a particular activity, please pick up the phone. We get lots of questions about whether or not roller coasters are returnable and when they can go to some of the theme parks and so forth. So keeping those types of questions in mind, if you're not sure, give a call. So can your new back really do that? And the research has shown, yes, it can. All adolescents should have approximately 60 minutes of daily physical activity for overall health. And this certainly includes our adolescents who have had spinal fusion. I think a lot of parents might be surprised at how fast they return to their activity, and it's okay to be a little bit nervous, but the research is clear. Our teens following spinal surgery have the same level of high intensity stop jump tasks like basketball, the same high effort running kinematics as their peers who have not had fusion. So yes, they can continue at those high level sports and activities once cleared. So what happens if your teen doesn't fit that statistics and the easy return of tasks? I like to highlight two particular time frames at 6 months and 1 year follow-up. Those are the two time frames to have a conversation with your physician and identify any limitations. If you had a very elite high level athlete before, how are they doing at returning to that sport? How are they doing at returning to gym class? Are there any areas where they're having difficulty or nervousness with, or if pain is a little more persistent? Physical therapy can certainly assist with this. And when we think about physical therapists who hold advanced certification in scoliosis specific exercise, it doesn't always have to be the Schroth program. Sometimes it can just be 1 or 2 appointments. I always recall the one teenager that I had who was a high-level ballet dancer, and she had no problems returning well within the appropriate timeframes back to school, back to gym class, and even back to ballet class. But she struggled with the sense of her new body in space and how to generate the turns for those lovely pirouettes. It only took one physical therapy appointment to break down that particular biomechanics for her, guide her, and by the end of a simple hour, she was pirouetting back into her classes. It's also important to keep track of if pain management needs to be continued in some way. If the pain becomes a limiting factor for movement, that's an important conversation to have. And again, as Dr. Lundine had mentioned, there's multiple tools available, not just within the pain medication, but other strategies as well. And never underestimate peer-to-peer support programs and counseling. So often, parents can do a tremendous amount of due diligence in finding the top surgeon or the top brace or the top physical therapist, but never underestimate the ability of a skilled mental health professional to provide parents and teens the necessary tools and strategies for managing some of the psychosocial and emotional components of this. Adolescence can be difficult enough across the board, let alone this journey of scoliosis that usually spans a number of years. So that can be an important, and I find often left out team component. So trust the fact that most of the time your body is going to adjust and return to movement. And if it doesn't, you have the team members in place. I want to thank all of our patients and families. You inspire us every day.
Thank you so much, Marissa. That was fantastic. So I'd like to introduce Dr. Kristopher Bonfield, who is an assistant professor at Vanderbilt University Medical Center. He'll be talking about beyond the spine in AIS, psychosocial difficulties and pregnancy.
So thanks for having me in this panel as well. We talked about, in the last 2 talks, many of the issues that you're dealing with your spine, both before surgery, directly after surgery, and then how you heal from that and get back into your daily life and sports and other things that you're planning on doing. We're going to take it one step farther here and talk a little bit past the spine and other issues that patients and families come to us in clinic and either are concerned about or have questions about if they're thinking about having children down the line. Are there differences with people who either have scoliosis or have had scoliosis and it wasn't corrected, or even more so have had scoliosis and they had their spinal fusion afterwards? So we're going to discuss some of those questions and some of the answers tonight as well. Let's see. So when we break down psychosocial difficulties, we're going to look at them today in patients with scoliosis. We're going to look at pregnancy as well as common questions that we had talked about. Psychosocial difficulties, when we looked up what was written out there and explored all the different papers that people have written over the last multiple years, there's generally three themes that come along with this, and that's body image, and that's eating, and that's mood that goes along with it as well. So we'll briefly talk about each one of those and how things may be different in patients with scoliosis versus patients who don't. So first, body image. When we look at studies, it's reported that almost half of patients that have scoliosis do acknowledge some sort of social limits, or that they look at their body and are little self-conscious about it, compared to teenagers who don't have scoliosis. Now, there are patients who don't have scoliosis who have these same problems as well, but there's just less of them. And we know that also self-reported body image, as we look at outcomes after the operations, it's important that the higher the higher rate that you feel good about your body image, that's one aspect that'll help you get better after your scoliosis, and we see better outcomes in those patients. We also know that patients who are thinner and whose curve isn't corrected as much at surgery don't do as well long term when we look at studies. So when we look at body image, it's very important not only before the operation about how you're feeling about yourself, but also afterwards, and how that'll help you heal and help you have a good long-term outcome. Eating behaviors is something that people at first thought was a problem, but as they look at it, patients with scoliosis demonstrate lower body weight, body mass index, body fat percentage, lean muscle mass, and bone mineral density. What that means is basically these are usually thin patients compared to patients who don't have scoliosis. And it thought that people were thin because they were eating in different ways. They were binge eating or fasting, or there was a fear of food. And as it turns out, that's actually not the case. So there's something that is built into these patients who just happen to be thinner and have less muscle mass and less bone mineral density compared to healthy counterparts. But it's not because patients with scoliosis eat any differently or think of food any differently than the patients who don't have scoliosis. Mood disorders is very important. This was brought up at the end of our last talk, is that scoliosis is a risk factor for higher mood disorder. So either having low mood, drinking, ultimately suicide thoughts are all increased in patients who have scoliosis. And so this is important, that if you are having some of these, or as parents, if you see that your child is having some mood problems that you think that just don't seem right, or that are causing problems in their life, it's something that we want to screen for and possibly even treat with counselors or other people who can help them. It also is because patients who come in with decreased moods, or who have other issues in this, also won't do as well after their operation. So it's something that we would want to know about beforehand. Interestingly, the size of the curve doesn't tell you how your mood is going to be, or if you have a big curve, you're going to have worse mood. If you're going to have a smaller curve, it's going to be better. So the actual size of the curve doesn't matter. We also know, interestingly, that increased treatment will also decrease your mood as well. When we talk about brace wear, we understand that it's very difficult to wear these braces for multiple hours, or for most of the day, especially in patients who are very active and are at school and in their teenage years. So something also to think about, that as treatment gets more and more intense, as you're wearing braces, as you're thinking about surgery again, it may be something that you bring up to your doctors and your medical team, so that we can screen for these things and treat it if there's something that's worse than we think. So psychosocial issues conclusion: patients with the AIS undergoing treatment often face issues with mood, as well as eating, as well as body image. We know that there are issues with what patients with scoliosis think about themselves compared to other patients who don't have scoliosis. We know that generally speaking, these patients are thinner patients, less body fat, but it is not that they think of food any differently or eat more or differently than patients who don't have scoliosis. And we also know that the patients with scoliosis are higher risk for having mood problems as well, and that can be something that we can either treat beforehand because we want to make sure that we know about these things before we continue treatment either with braces or surgery. The other question that we get, not including the spine operation, about life after is pregnancy, because a lot of the patients that we treat are girls, and especially as curves get larger and we're talking about scoliosis surgeries, most of them are girls compared to boys, and these are teenage girls mainly. So thinking ahead to what happens if they want to have children in the future, is this something that their scoliosis will affect, or is this something that the fusion surgery will affect them as well? So we looked at this as well. We reviewed the papers that were published. We also looked at our pregnant patients here and came up with some rules of thumb here. So one of the main questions is, how does the scoliosis change the timing, and can I have kids with scoliosis, or can I have kids if I have scoliosis? So women with scoliosis are slightly less likely to become pregnant and may need some treatment in order to get there. But when you look back, mothers with scoliosis can have the exact same number of children at the same mother age, which is important, and at the same term as patients who don't have scoliosis. So when you look at it, the answer is yes. You can have kids, and you're likely to have the same number of children and at the same ages of both you and at term as your child. The next one is, does the spine change during or after pregnancy? And it starts with back pain, and back pain is very common in pregnancy. And this is patients who do and don't have scoliosis, and many of them, over half of them, will have back pain, and it may get severe. When you talk about scoliosis mothers, they experience somewhat higher rates of back pain, but that gets better after pregnancy is finished. And patients who had surgery did not have more back pain compared to those that were treated or who didn't have surgery or with braces. And so some women will experience a minor curve during their childbirth time, but we don't think that it progresses enough that it changes anything as far as if it would change your treatment or if it would change any symptoms that you're having. So in general, are there temporary changes to the spine? It's mainly back pain, and people without scoliosis have these as well. But on average, these get better after childbirth. And then anesthetic. Can patients with scoliosis, especially who have fusions, can they have spinals? Can they have epidurals during their time of pregnancy? And the answer is yes. And we looked at this, and many patients with scoliosis, especially those with spinal fusions, can have those types of the pain control during when they're giving childbirth. The other thing is there a different rate between patients with scoliosis who are having C-sections not? And the answer is no. It's the same rate between both of them. And then complication rates such as preterm labor or other things are the same between patients with scoliosis and patients who don't have scoliosis. So on the whole, you can expect similar pregnancies and birth that go along with patients who have scoliosis, who are corrected with bracing and with surgery, and patients who do not have scoliosis at all. So again, most women are able to have children if they so choose at the same ages as the patients who don't have scoliosis, and the same term with the kids. Some back pain is common in scoliosis in women during pregnancy. It's also common in patients who don't have scoliosis, and these get better after childbirth. And again, when you look at the actual complications, such as giving birth too early or having failed spinal anesthesia, it's the same in patients who have scoliosis, including those with fusions and who don't. And so this is all good news for for girls who have scoliosis and are diagnosed early on in their teenage years and wish to have families later on, even if they have their spinal fusion surgery or treated with braces as they go along. So again, thank you for having me involved, and I think Dr. Lee is going to come back on and we'll be happy to answer questions. I see some are coming through the chat rooms already.
Thank you so much, Kristopher. I think we'll go on to the question kind of for the panelists, and I think we have kind of several questions kind of up right now. I think the first question is actually for kind of Kristopher Lundine in Australia. So one question is, what can I do to get myself kind of ready for surgery to kind of decrease pain and maybe improve this constipation issue that you talked about? Are there things you can do before the surgery that you can kind of, that can help with this?
Absolutely. So there's many aspects to kind of preparing for surgery and whatnot. A good rule of thumb is the stronger you are, the fitter you are going into surgery, the stronger and fitter you are will be coming out of surgery. So a real common kind of term that's become popular is something called prehab. And from a strength pain point of view, that some patients like to start some physiotherapy or learn some of the exercises they might do after surgery, learn them and get good at them before they go in for surgery. So if you're thinking you might want to do some Schroth type exercises after surgery, do some of that type of physiotherapy, learning those exercises before surgery, getting those muscles strong can help your rehabilitation afterwards. And there's some good evidence to show that this is beneficial. So sometimes meeting the physiotherapist that you're planning to see after surgery before you ever undergo surgery is a good idea. In terms of the more specific constipation type stuff, of course, having a good diet is always a good idea before surgery. If there's any concerns, if you have had any history of eating disorders or things like that, it's important to discuss with your surgeon to look at nutritional status. Constipation, one of the key aspects is making sure you're well hydrated. And a lot of people ask, well, how do I know if I'm well hydrated? It's kind of a very basic, but if you're peeing clear, you've got lots of fluid on board. If your pee is dark yellow, you're probably a bit dehydrated. And so going into surgery well hydrated, of course, at the time of surgery, your anesthetist will be giving you lots of fluids and things like that to make sure you stay well hydrated. But going in, making sure your gut's well hydrated is a good idea. Simple things that can also help, depending on what your normal diet is. If you're a big fan of things like black licorice, dried fruit, fruit juices, things like that before surgery will just help the guts be going a little bit smoother than after surgery. If you have any history of constipation or problems with that, having a discussion with your surgeon beforehand and maybe starting on some medication before surgery to help get the guts moving a bit can also be beneficial.
Thanks very much, Kristopher. We have another question, and this one's for Marissa. So you talked about kind of exercises kind of after surgery and the kind of some exercises before surgery. So one patient wants to know, without a physical therapy degree, what are some general things I can do to prepare myself kind of for the surgery, and what are some general things I can do to kind of recover faster?
So unlike some other areas of orthopedic surgeries, like, for example, knee replacements and hip replacements, you know, we have a lot of research that has delved into the preoperative physical therapy. But as Dr. Lundine mentioned, the more fit you are before, the better going through. So in the absence of general physical therapy, keeping in mind that most of our teenagers with adolescent idiopathic scoliosis are otherwise healthy and active, maintaining that level of activity becomes even more important. So sometimes be mindful if the traveling and the stress of the family as you're trying to prepare for surgery has taken a few weeks and lessened physical activities and outings, perhaps keeping track of that and making sure that that doesn't happen, that in fact, those few weeks leading up, we have maintained, if not exceeded, your typical types of general exercises, walking, running, going out and playing some sports and activities, keeping that as healthy as possible preoperatively. If for some reason you know that your particular teen or you as an individual are not necessarily that athletic or active, this is the time to have that conversation with your team and perhaps invest in some skilled physical therapy preoperatively, whether it's an actual Schroth program or whether it's just general activities and exercises. And again, not necessarily a full scope of sessions, perhaps just one or two training to let you know what's available in your community, what's available in your local gym, and reviewing some total body exercise machines and exercise options for that individual, giving them the full scope, not necessarily weeks of PT, but giving them the tools to what to look for in their local community services is an option as well.
Thank you very much, Marissa. That was fantastically informative. We have one other question from a patient who asks, if I have pre-existing psychosocial issues, if I kind of have anxiety disorder, will my recovery be longer or kind of worse? And I'll have kind of Dr. Kristopher Bonfield answer that question.
Yeah, I think that studies have shown that it can make things worse afterwards, and part of it can be as close to surgery as just having different control of pain, staying longer prior to going home. Also, if you're anxious or if your mood is low, then you're not going to want to get back into the same type of things you were doing previously. So you may sit around a little more, which is going to cause you to become more stiff and not get back into the life that you had prior to. And so that's why it is very important that if there is some question about whether or not your mood is low, or if you're having too much stress or other issues with that, we can screen forward or get you talking to team members who can help you out with that, because it does show that if you go into something just like they were just talking about, physically fit going in, the better you are, you'll come out better. It's the same things when it comes to mood and stress levels as well.
Right. Fantastic. Does your hospital have a kind of team that goes through that with the patients?
It's more of us screening, and actually parents sometimes come up, afterwards. We'll sit there, talk about surgery and say, well, they were more active beforehand. I don't think it's their back that's hurting. They're not as interested in their friends. They're not as interested in going outside. Is there something else that's going on? And prior to having surgery, and then making things painful for that short amount of time as they come back from it, we may screen them and then pass them off to team members who can help them and get their mood and and get their mind ready for surgery prior to actually doing it.
Okay, thank you very much, Kristopher. We have one other question from kind of patient, and they write that their daughter's a competitive swimmer, and the parents are wondering whether or not spine surgery into the lumbar spine will decrease overall flexibility and impact kind of that sports participation. And I was wondering if Kristopher Lundine can kind of take that answer.
Absolutely. So it's a good question, and a very valid question, that anytime we're fusing parts of the spine, there's the potential for a bit of loss of motion. As Marissa kind of touched on in her talk, the getting back to activities, most patients who undergo spinal fusion for scoliosis correction get back to absolutely all the activities that they were doing before. Now, if you're looking at the extremes of motion, so some patients who do a lot of gymnastics, things like that where I find some patients find a bit more restriction is doing back bends, back walkovers, things like that. I actually have a couple of patients who are national level swimmers in Australia and have recovered very well after surgery and are back doing national level swimming. So I wouldn't consider it a contraindication to that as well. And I would expect that you'd be able to get back to swimming. The more of the spine we fuse, the more limitation to activity there's going to be. So in some patients with very severe curves, who were looking at fusion down into the pelvis, and not so much the idiopathic group, that certainly there's going to be more stiffness there. But when you leave alone that lower lumbar spine, and if you're dealing with just part of the lumbar spine, most patients really don't have any activity restriction other than the normal stiffness that comes in the early aspect of surgery and needs to be worked out through rehab. But most patients find they can get back to full activity.
Sure, that's fantastic. I think to not be too technical, is there a level at which you know, you would say, you're probably not going to return to kind of normal motion, or you're not going to have very normal motion. L3, L4, S1.
We love to try to stay at kind of L3, L4, that if we're fusing down to L5, we tend to find we were seeing more stiffness, and certainly when we're fusing down to the sacrum and pelvis, there's much more stiffness. When we can leave a couple motion segments in the lower part of the lumbar spine, most patients do very well in terms of day-to-day and even higher level function.
All right, fantastic. And Marissa, I wanted to ask you, do you see any patients who just don't quite get back to their preoperative sports kind of activity? I think I think in general, we agree that most patients can return to what they want to do, but is there a subset that never quite make it back?
Yes, there is. There's a couple of new research studies that are starting to look at the multiple factors surrounding that smaller percentage that don't seem to get all the way back to their previous level. And there's multiple factors involved in that. It's not always that we would, you know, think it has to do with the fusion level. As Dr. Lundine mentioned, certainly there are some activities, some more advanced movements that if the fusion is longer and deeper into the lumbar spine are certainly going to be limited. So that's kind of expected and typically explained and discussed in more detail ahead of time and not necessarily a surprise. But the area when there's a teen who struggles with returning, you know, 6 months or a year out, it can be multiple factors. It can be that psychosocial. There's even a component of how the parents perceive their child as being vulnerable. You know, having gone through this experience of a larger surgery can make a parent feel like their child's more vulnerable and needs more protecting, and that can impact a child's performance or the recovery of that. I know the kids are usually ready to go back, and the parents are not uncommonly kind of holding them back a little bit more. But again, there's multiple factors. So if there's some changes in mood or behavior, those are also some of the important factors that need to be discussed early on at that 6 month and 1 year follow-up. If they're not getting back into it, if they're not back into their peer group and their sports, is there a psychosocial component to it? If it comes right down to just a biomechanics, I find that physical therapy really deals with that very well. There are just some complex movements that they can't seem to figure out how to move their new body in their old movement pattern. And that's where skilled physical therapy comes in, helping them to break down the biomechanics of what they used to do with their new spine. You know, I always say the brain had years to kind of develop the postural sense of and biomechanics as the scoliosis curve was developing. And then boom, in one day they woke up and they have a completely new biomechanical center in line. So for some, their brain processes a little bit slower and just might need a little bit of help in figuring out some of the higher level activities. But again, keeping that 6 month and 1 year time frames to really identify them as early as possible can really help limit that lack of return.
Thank you, Marissa. I think it's important to underscore that a lot of what we're talking about, and it really points to the idea that there are other things besides the surgery itself that can impact recovery as well as long-term outcomes. So I think last question for Dr. Bonfield. We have kind of one patient who writes kind of their child is planning to do Division I sports in college, and they have a large scoliosis. Should I have the surgery now or wait?
Well, I think that's going to be different for each patient, and that depends on multiple different things. And part of it is the age of the patient. Now we know they're going to college, so they're going to be around that 17, 18, 19 year old time, and they're probably finished growing unless they're one of the late blooming males who continues to grow into college. But it also depends on what sport they're playing, and it also depends on what size their curve is right now, because if it's something that has gotten to the point where they are talking about surgery, then it's going to be a fairly large curve. But if it's not causing them any pain or any problems, and it probably doesn't at this point, if they're going to play D1 sports, because they must have been good at it going through high school, then you have to talk to your surgery team and say, well, what are the risks of waiting another 4 years or 3 years, however long it's going to happen, and you have to decide what sport it is as well, and if there are any risks that go along with that. And so I think that there's various factors here that enter into it. But ultimately, if it's something that it's a sort of borderline curve and it's not causing them any problems, likely waiting until they're 22 instead of being 18 or 19 doesn't change things too much. But individual patients are going to be different. And so there are some patients who we would say, yes, you should have surgery now and then recover and seeing if you can go back to sports, or this may change how what your sports will be like going forward.
All right, thank you very much, Kristopher. I think we are kind of out of time for this particular webinar. I would like to thank very much the panelists for their excellent input. I would like to thank the audience members who kind of have had the patience to listen to all this information. I want to remind everybody that the copy of this particular webinar is available on the SRS website at the following location on the screen. And just wanted to remind everybody that the next patient webinar is on June 10th at 7 p.m. and the topic will be bracing for spinal deformity. Thank you again, everyone, and have a wonderful evening.
Good night.
Thank you.
Good night.